trying to determine how much pain somebody's in. You go into the doctor, you say, I've got a migraine headache, and he says, well, how bad is it? And on a scale of 1 to 10, how bad is it? That's usually what they say, something stupid like that. And I don't know what you say. I mean, I don't usually measure my pain on a scale of 1 to 10. I usually measure it on it's there or it's not. So it's on a scale of 1 to 2, how bad is your pain? 1 is not there at all, and 2 is really hurts a lot. That's usually the way I figure it. But there are ways that we can measure. We can measure how much muscle tension you have. One of the things that we know is that when you have the pain in a select area of your body, it'll hurt. It hurts, and it makes you wince. And when you wince, of course, you tighten your muscles. And when you tighten your muscles up, sometimes it makes the pain worse. Because especially if it's a muscle pain or a joint pain, you're holding that joint in a position that gives you pain. This is kind of a problem. We see the same thing with migraine headaches. A lot of times, migraine headaches start out as relatively simple problems with not very much pain, but because you tense up more and more and more and more, the migraine headaches get worse and worse and worse and worse. So one of the things that we try to do is we try to allow you to relax one way or another, and sometimes it'll make the migraine headaches go away, and sometimes it doesn't. So muscle tension is huge. We can also look at your heart rate. If your heart is beating very, very rapidly, that means that the body is trying to send blood to the area to cure it or to take care of the problem. We can watch your breathing rate. When people are in pain, usually they take shallow breaths. Their breathing also tends to be fairly rapid. Your blood pressure, of course, goes up. One of the interesting things is, so we can look at somebody, and usually we can tell how much pain you're in by how much muscle tension you have, whether you're grimacing or not, whether your heart rate is fast, and whether your blood pressure is elevated. This will give us an idea as to whether you are in, how much pain you're in. There are measures that we can use. Pain behavior scale targets behaviors that include vocal complaints, facial grimaces, awkward postures, and mobility. The biggest problem is that we are dealing with individuals, we're dealing with nurses and doctors. A lot of times these guys don't like to look at patients. They don't like to touch patients. They don't like to smell patients. So the biggest problem is that these guys don't really pay attention to what the hell's going on. But the reality is that if you look at people and you watch them, you know when they're in pain. If you've ever really seen somebody in pain, then you know what it looks like. But the problem is, of course, these people are used to ignoring these kinds of things. And so they do. And they're not very good at determining if somebody is really in pain or not. Pain Response Preference Questionnaire, the PRPQ, measures the range of potential pain-related responses desired from your partner or your spouse. So they don't ask you the questions, they ask your partner or your spouse the questions. And of course, there are also partners and spouses that don't pay attention to their significant others. So this may not be the best way to do it either. Pain rating scales are numerical ratings or a pain diary. And of course, that has to do with, on a scale of 1 to 10, how bad is your pain? Is it worse in the morning? Is it worse when you get up? Is it worse after you go to the bathroom? Is it worse after you've been walking? Is the pain relieved at a select point? And of course, we can do that. Kind of hard to tell the kids. Kids don't want to be in pain. Adults sometimes do, but kids don't want to be in pain. So a lot of times we have to use the pictures of faces. How bad do you feel? The children's fear scale captures dimensions of pain and fear in children. This is the picture I was talking about. Which one is you? And of course, this has to do with your pain. Most adults don't usually cry if they're in pain. This is known as the McGill Pain Questionnaire. This is really kind of interesting. This is the McGill Pain Questionnaire as well. There we go, a copy of the McGill Mazarek, Melzack pain questionnaire. We're going to talk about Melzack in just a second. On a scale of 1 to 10. The McGill pain questionnaire, this is page 1, of course. You're late. Did you have another flat tire?
Oh, no.
Okay.
I just want to be fashionably late.
You thought you'd get me before Johnny anyway. He was here when I opened the door. Cool. He helped me open the door. Oh, wait a minute. I can sign people in. What have I got? Johnny's here. Tyler's here. Okay. Anyway, so this is the McGill pain questionnaire. And I have given you a copy of the McGill-Melzack questionnaire. Pain pathways, unlike other senses, pain is not triggered by only one type of stimulus, nor does it have a single type of receptor. And this is really kind of a problem, because sometimes we get a pain in one place, and it won't correspond to the damage that has been done. I was telling you about my wife and her hips. My wife and her hips. She has hip problems, and she was having problems in her lower back. It was the pain. There was no reason for her to have back pain. She actually didn't have any damage to her back, but she did have damage to her hips, and because of that, it was as it was going up to the brain and coming back down. It was dislocating the pain into her lower back. So this is really a kind of an interesting problem that we have as medical personnel. A lot of times it's very difficult to tell what we're really dealing with. So sometimes we'll see pain in one place and we will actually see the damage in another place. I can remember a gunshot wound. This guy was shot between the eyes, and he swore that he couldn't swallow, that his throat hurt, and he was spreading all the way down into his neck. Eventually he died, and that's not the important thing, but the fact was that your head really doesn't have very many pain sensors. Your face does, but your brain doesn't. Your brain doesn't have any pain sensors at all. Here, this guy had a bullet that had bounced around his skull cap a little bit. And he was complaining about pain in his throat, and he was having a hard time swallowing. And eventually, of course, he died. But that's not important. What is important is the fact that pain is very difficult to localize. We have no idea where it is. We can have no idea where it is. It really all depends on what's going on. Let me think of another instance. The gunshot was not a very good one. And he was shot from pretty far off, and he was shot by a .22, and the shell had almost spent itself, so that there wasn't very much power behind it. And because of that, normally a bullet will go in, and it has so much power behind it that it'll go straight through. But this one kind of went in, it got stuck on something, and started bouncing around a little bit. And that's what killed him, actually, was the fact that it was an unspent bullet. If it had been, it was a .22 short. If it had been a .22 hollow point, it would have gone in and just smashed, and it wouldn't have bounced at all. If it had been from closer range, you guys don't need to know this. I'm sorry. If it had been from closer range, then it would have had enough power to go all the way through. Yeah, exactly. It would have gone out the back of his head, and he probably would have survived. Let me think of another case. We had a guy that came in. He cut his hand off. He was using a drill press or a press, some kind of a press, and he got his hand stuck in there, and it just cut his hand off really clean. It was really kind of amazing. No pain. There was no pain. He said the only problem was he was having problems with his shoulder. Of course, he's going like this, and he's got, there's no hand there. It was just kind of bizarre. But he said, I got problems with my shoulder. But of course, he had his hand cut off at the wrist. the cleanest cut I've ever seen. It was amazing. It was like somebody had taken a cleaver and just cut it and just chopped it. So we thought we were going to be able to reattach it, of course, you know. Sometimes you can reattach fingers and whatnot. So they took him up to surgery and tried to reattach it. I mean, and you would think this guy would be going, oh my God, I just lost my right hand. This is horrible. Nothing. He's telling jokes. He's sitting there. He said, at one point, I was drawing his blood. He said, I'm giving you the finger with my right hand. It's right over there. You know, one of those kind of deals. Oh man! But he was complaining about his shoulder. Anyway, pain pathways, unlike other senses, pain is not triggered by only one type of stimulus, nor does it have a single type of receptor. Free nerve endings are sensory receptors found throughout the body that respond to temperature, pressure, and painful stimuli. Nociceptors are specialized neurons that respond to painful stimuli. So we have nociceptors all over our bodies, except in our brains. The interesting thing is that you can do brain surgery on somebody with Novocaine, and that's it, just a localized painkiller. Just a localized painkiller, or lidocaine. So you just numb the skin, actually. It's not even the skull. The skull doesn't have any pain receptors either. And then you can just go digging around in the brain all you want, and the guy won't even know it. I mean, he can, and they do this. They'll have surgery where the guy is completely awake. He's completely lucid. Brain surgery. And sometimes they do that so that they can tell what areas of the brain they're dealing with. Really kind of interesting. Fast nerve, there's two types of nerve fibers. There's myelinated fast nerve fibers. They're relatively large. These are for intense acute pain stimuli. So they will tell the brain if something has happened or something very painful has happened. And these are myelinated. There are other short fibered, unmyelinated nerve fibers that have to do with aching pain. If you think about it, there's a really good reason why we need myelinated, large, fast nerve fibers for acute pain, if you think about it. Let's say that this happened to me the other day. I was cooking and I grabbed a hold of the handle of my frying pan, and it was metal. I'm like an idiot, not thinking, I'm thinking of something else. Grading your papers, I'm sure that's what. Anyway, I grabbed a hold of it, and I let go of it really fast because it was hot. I didn't blister myself. I let go of it so fast that I didn't actually blister myself. Now the reason that I didn't blister myself is because I didn't hold on to it for very long. Because the pain sensors told me to let go of the damn skillet pan. Right? If it had been unmyelinated, slow nerve fibers that I was relying on, I would have held on to it and I would have gone, oh, that's hot, I better let it go. But since it was fast, I let go of it before I even thought about it. I mean, I didn't even have a thought about it, but I let it go. And everything was fine. Anyway, so we have aching pain and we have sharp pains. The substantia gelatinosa is the dorsal region of the spinal cord where both fast and slow pain fibers synapse with sensory nerves on their way to the brain. Referred pain is pain in an area of the body that is sensitive to pain but caused by disease or injury in an area that has few pain receptors. And of course, the area that has the fewest pain receptors is your brain. Another area of your body that doesn't have very many pain receptors is the antecubital part of your elbow, this portion right here. It doesn't have hardly any pain sensors. And for that reason, this is where we draw your blood. A lot of people can't feel the blood being drawn. They think they can, and they think they should, so they go, ow, but then they actually can't feel it at all. If you can distract them, they may not feel it at all. I used to do that all the time. I used to tease them, or I'd say, look over here, and then I'd stick them, that kind of stuff. And you can actually keep them from realizing what's going on. Okay, I'm going to skip that one. Substance P is a neurotransmitter secreted by pain fibers in the spinal cord that stimulate the transmission cells to send pain signals to the brain. Now the reality is that most of our analgesics, the things that we take to keep us from being in pain, such as Tylenol or ibuprofen, well, Tylenol and ibuprofen both block substance P. And because it blocks substance P, of course, the pain message isn't making it up to your brain. And that's why they work as painkillers. Along with glutamate, substance P continuously stimulates nerve endings at the site of an injury and within the spinal cord, increasing pain messages. Now this gets really interesting because we can block those pain messages. There's a way to block the pain messages. And we do it all the time. We do it ourselves. And we do that by creating a counter feeling. So if I've got a pain here in my arm, if I scratch my arm over here where I can feel it, now I've got that message is trying to get to my brain, but which is going to get through? Is it me scratching or is it the pain I've got in my forearm? Which is going to get through? Well, part of the time this is going to get through. And part of the time this is going to get through. But I can block it by rubbing it, by creating a counter message to my brain. So you can actually block pain for a short period of time. Eventually what will happen is, especially if there's a lot of damage from whatever it is that's on my forearm, eventually that message is going to reroute itself and it's going to get to the brain that way. Pain is really fascinating. It's almost impossible to deal with on the long term. Short term, easy, no sweat. Take an aspirin and call me in the morning. But long term, the problem with pain is that it will reroute itself. The human body wants to fix itself, and it thinks that it has to fix itself by making sure that message gets to the brain so that you don't damage yourself. So it will reroute itself. So no matter what you do for the short term, it will potentially get there in the long term. And this is one of the reasons why if somebody's got back pain or somebody has any chronic pain, I was talking to one of my colleagues downstairs, they were suffering from sciatica. And, terrible. I used to have sciatica. I've had sciatica, but he, see, I've already identified him. He has a problem. Sometimes he gets up in the morning and he can't walk. Sometimes he gets up from his chair and he has sciatic problems. Sometimes his sciatica will go all the way up into his back, and that probably has to do with muscle tension more than anything else. But even if you take ibuprofen or you take Tylenol, it's only going to work for that short period of time. The next time you take the ibuprofen or the Tylenol, if you haven't given it enough rest time, enough pain time, then what it will probably potentially do is reroute itself, and so the pain's going to come back anyway. There's not a whole lot you can do about it. And this is one of the reasons why it's so difficult to deal with pain. This is one of the reasons why they give you opioids for pain. In the old days, before 2001, we didn't really give you opioids for pain. Only in extreme cases did we use opioids. Now all you have to do, it's kind of like marijuana. When they first legalized marijuana for medicinal reasons, the only people that came in were people that really had problems and they needed that marijuana to control that problem. All of a sudden, everybody's got all kinds of interesting problems. And they're all going in to have, because they need the pot, man, come on. I told you the story about Montana. They passed a law in Montana that to legalize medical marijuana. Well, they thought they were going to have about 4,000 people. That's what they were telling everybody. So people voted for it. I voted against it. I was living in Montana and voting in Montana at the time. I voted against it. I didn't think it was a very good idea. It's never a good idea to give people a controlled substance. But they voted it in 60 to 40. And the 44,000 people that they were talking about initially turned into 40,000. Well, it's now up to 80,000. This is like 1/8 of the population in Montana are smoking pot in order to get rid of pain. But they had initially said 4,000, and now it's up to 80,000 people, as odd as that seems. A lot of people in pain. Montana evidently is a pain or something, I don't know. Enkephalins are endogenous opioids found in nerve endings of cells in the brain and the spinal cord to bind to opioid receptors. Enkephalins may regulate how much substance P is released and therefore how much of the slow pain system's message reaches the brain. And this has to do with enkephalins. The periaqueductal gray area is a region of the midbrain that plays an important role in the perception of pain. The periaqueductal gray region activates a descending neural pathway that uses serotonin to close the pain gate. So the happier you are you ready for this? The happier you are, the more likely that your pain gate is going to close. How about that? So happy people don't have the pain that unhappy people do. Isn't that exciting? All you have to do is smile. All you have to do is smile and your pain will go away. You think I'm kidding. I'm not. This is the way it works. The anterior cingulate cortex is the front part of the cingulate cortex, which resembles a collar like this. Okay, I can't say that word. I'm from Indiana and I can't say collar. What collar is this? This is my collar. I say it exactly the same way. They're homonyms, but other people, they say them differently. And people make fun of me because I can't say those two words. There's actually three words. The other word is C-U-L-L-E-R. It's somebody who culls things, a culler. When I worked in the concrete block factory, I was a culler. I would take out all the bad blocks, the ones with cracks in them, they had chips off of the ends of them, and I would put them in a special stack so that we could break them up and make new blocks out of them. I was a culler. But the problem is, what color is my color because I'm a color? You know, that was the problem. So, because I'm a Hoosier, I can't pronounce those three words correctly, obviously. People from Chicago don't live in Chicago. They live in Chicago. Chicago. So they don't even know where the hell they live. Or I can't pronounce the name of their city. The anterior cingulate cortex plays a role in the cognitive modulation of pain. Endogenous opiate peptides are opiate-like substances naturally produced by the body. They function as information messengers, and they are what tell us to be in pain or not to be in pain. Neural activity resulting from stimulation of the midbrain's periaqueductal gray region activates inhibitory neurons in the spinal cord. These in turn act directly on incoming slow nerve fibers to block pain signals from being relayed to the brain. So if you've ever watched a football player, he hurts himself, he comes off the field, all of a sudden they put him back in. Well, what in the world's going on? Well, what has happened is this whole mechanism has kicked in, and now he's not nearly as much pain as he was before. And this used to happen all the time. Doesn't happen as much anymore. In the old days, they would bring somebody would have get hit in the head, and they'd bring him off the field, and as long as he wasn't in pain, they'd let him go back in. Now, of course, they have concussion regimens that they have to go through, and they have to determine that he isn't damaged. It used to be the same way with ankle damage or ankle sprains or whatever. Somebody twists their ankle or something, all of a sudden, they tape them up and they send them right back in. Well, they don't do that anymore. Now they have to do they have to x-ray the ankle to make sure it's not damaged. Once they do that, because football players, of course, they're used to all these things. Their mechanisms for blocking pain are very acute. And because of that, a lot of times they are damaged and they need to come out of the game because potentially they'll do more damage to themselves. And this is one of the reasons why football games are so interesting now. This is one of the reasons why the taxi squad, they carry a lot more players than they used to. It's because they have to bring them off the field. They have to x-ray them. They have to do this. They have to do something else. And potentially they will not be able to go back in the game. The slow nerve fibers contain substance P and glutamate. When the nerve fibers release of substance P is inhibited, as it is here, the descending pain signal is aborted, prevented from traveling to the brain, and that's what we need to do. We need to block that substance P. Well, there's a natural way to block substance P, or you can take acetaminophen or ibuprofen, and that will block the substance P. But the question is, how long does it take for the acetaminophen or ibuprofen to get into your system? I'm sorry?
Half an hour.
Yeah, 20 minutes to half an hour. You have to digest it. Okay. And if you're excited, you're not going to digest it at all. It's just going to sit in your stomach. Now this can be a problem, especially if it's aspirin or acetaminophen, because acetaminophen they're acids, and they'll burn a hole right through your belly. I mean, they can, but of course it doesn't happen that way. So you don't want that stuff to sit on your stomach. I was going to get rid of this thing. I don't know why I didn't get rid of that picture. Stress-induced analgesia is a stress-related increase in tolerance to pain, presumably mediated by the body's endorphin system. So the reality is that something might have happened to you to cause pain, but because you're in a stressful situation, you don't feel it. And this is one of the reasons why football players in a stressful situation, they injure themselves. They don't realize it because of the stress-induced analgesia aspect of endorphins. So they don't realize that they're hurt until somebody looks down and says, "Oh, look, your finger's hurt," or that's something you're bleeding. And this is I've seen this a lot. People will get something will happen to them and they'll start bleeding. They won't realize they're bleeding until it either gets in their eyes or they feel the wetness in their pants or something. They won't realize that they're bleeding, despite the fact that they've got a hole in them someplace. Their skin is broken, and they're bleeding out, but they don't even realize it. Naloxone, the opioid antagonist, is used to block the effects of natural opiates and painkillers. So we can do that. I don't know why we would do that, I guess, to tell you that you're in pain, I guess, would be the reason why. Chronic pain conditions and pain sensitivity has a genetic component. There's one group of people in the world who are more sensitive to pain than anybody else. And oddly, it has to do with hair color. I know, weird, isn't it? So who could that possibly be? Who are the people that are the most sensitive to pain? We've been talking about this for a really long time, and they couldn't prove it until about 15 years ago. Now we know that this is true. We've been saying that these people are more sensitive to this, that, and the other than other people. That they're not medication. You have to be aware of what you're giving this select individual, because sometimes medications won't work on these people because they're less tolerant to pain. Yeah. Yeah, good job. Thank you. We appreciate it. We were parboiling all of our students.
Redheads?
Redheads, exactly. It's redheads. Redheads are the most sensitive. Yeah, and one of the reasons is because those of us who are not redheaded, we have melanin in our skin. You guys have more than I do. That's why I'm so pale. That's why I sunburned myself so badly over the weekend. Anyway, I'm fairly pale. But redheads, they have less melanin as well. But there's something genetic about redheads. It's a recessive trait. You have to have two redheaded genes in order to make the person redheaded. It's really kind of bizarre. My mother had red hair when she was a child, but she wasn't. She had auburn hair, which is actually brown hair that looks red in the sunlight. Anyway, but redheads really are more sensitive to pain. When I was in the service, I was in basic training, and we were walking through and we're sticking our fingers out, and they're sticking us with a needle, and they're drawing a little bit of blood from us. I mean, it wasn't that big a deal, just a couple drops. It's not like we're going to bleed us to death. They only made a hole about this deep. I mean, it wasn't that big a deal, right? So we're walking along, you know, they're sticking everybody, and everybody's like, oh my God, I don't have my fingers stuck, you know, that kind of stuff. Nobody cared. It wasn't that big a deal because it didn't hurt that much. Well, they stuck this, the guy in front of me, he was a redhead, and he also claimed to be a Cherokee, but that's neither here nor there. We won't go into the Cherokee part. He's also from Cuba, Missouri. I have no idea what that means. Anyway, he was a Cherokee, redheaded Cherokee from Cuba, Missouri. Anyway, he's standing there, and they stuck him in the finger, and it's hurt him, it scared him, it did something. He jumped back, and we're in kind of in a hallway, but it was a big hallway, and he jumped back so far that he hit the back of his head on the wall, knocked himself out, started bleeding from the back of his head. I know, it was really kind of bizarre. Anyway, he knocked himself out, and of course the rest of us are just laughing like crazy. But of course, this guy's real sensitive to everything. He's just sensitive to everything. They boarded him out of the service because he was too sensitive to pain, as strange as that sounds. So he didn't last very much longer. Complained about everything. I mean, everything. And I figured it was because he was a Cherokee. No, it was probably because he was a redhead. Of course, I'd run into American Indians before, and of course, none of them looked like him, even close to what he looked like. This guy didn't have any native facial features. His hair was red, you know. But he claimed to be a Cherokee from Cuba, Missouri. Anyway, we boarded him out. He's gone. Genes seem to mediate anxiety and depression. Genes affect individual sensitivity to painful stimuli. The SCN9A encodes instruction for sodium channels that relay painful sensations, and of course redheads. Strangely, this gene is connected to hair color, as odd as that may seem. COMT is one of the several enzymes involved in metabolism of catecholamine neurotransmitters. So we have two genes that have something to do with pain. The SCN9A is the most important because that's the one that's actually tied to red hair, as confusing as that is. The second most sensitive to pain, of course, are blondes, which is kind of interesting. The vast majority of people in the world have darker hair than that, have brown hair, or they have black hair. But those two mutations, blonde hair and red hair, both are very, very sensitive to pain. The gate control theory was proposed by Melzack and Wall in 1965. It's the idea that you can interfere with information, that there is only one pathway, and there is a gate that has to open up in order for the pain message to get from one place to the other. So you can close that gate. You can interfere. You can send another message through that gate that will interfere with the pain message. So you can actually block it. If you've ever watched a baseball game and you've watched somebody getting hit with a baseball, the one thing they tell the guys to do is not to rub it. Well, the reason they don't want them to rub it is they don't want to show the pitcher that they were in pain. Because if you rub something, an area that hurts, it actually makes the pain go away. Why does it make the pain go away? Because of the gate theory. I mean, you can only get one message at a time. And if you can interfere with that pain message by rubbing it, it's not going to hurt nearly as much. And of course, the pain message isn't going to be able to get there. And that has to do with the gate theory. And that's Melzack. And Melzack, of course, is the other guy on this sheet. McGill and Melzack. Did I give you one of these? This is the McGill-Melzack pain test. It's not important, except that I just thought you got it. They give these things away like anything. Phantom limb pain following amputation of a limb. False pain sensations that appear to originate in the missing limb are known as phantom limb pain. fascinating stuff. I don't know if you've ever been around an amputee, but a lot of times they'll complain that their foot itches. And they want you to scratch it. Well, you can't scratch it, it ain't there no more. It has something to do, and they're not exactly sure why this happens, but it has to do with their stump. They're getting information, I know, they've got these nerve endings that don't have, that should be going down into their limb that aren't there, but the nerve endings are there, the limb's not there. So potentially they're getting information from these nerve endings. And of course, sometimes it's a burning pain, sometimes it's a stabbing pain or a shooting pain or a cramping. The one that I've heard the most is tickles. It tickles. Can you scratch it? This is driving me crazy. I can't get to it. I can't scratch this thing. Anyway, phantom limb pain is experienced by 65 to 85% of amputees. It consists of cramping, shooting, burning, or crushing. And like I said, the tickling is the one that I've heard the most. Underlying mechanisms of the phantom limb pain remain a mystery. It seems fairly obvious to me that it has something to do with those nerve endings that no longer are going into the limb. As people get older, there is a progressive increase in reports of pain and a decrease in tolerance to pain. So as we get older, we become less tolerant to pain. Not me. I haven't had any problems with pain. And it pisses doctors off. They want to give me drugs so that I don't hurt anymore. Well, I don't hurt at all, so this doesn't make any sense. But most people, of course, they get all these strange pains. As I told you, I don't have an ACL in my left knee, so my left knee is kind of unstable. But I really don't have any problem with it. It doesn't hurt. It should hurt. It's supposed to hurt, but it doesn't. So what does that mean? Is there something wrong with me? Should I go to the doctor and get fixed so that my knee hurts? What do you think? Should I go? The doctor wants me to go. Idiot. The doctor's the idiot. It's not me. I'm not the idiot. He thinks I'm an idiot because I don't hurt. Anyway, as you get older, of course, you get more and more. You get more and more pains. I do have pains. Mostly it has to do with me lecturing. One of the reasons I move around so much is because if I don't, my back gets sore. It gets stiff. So when I have to walk downstairs after lecturing for 3 hours, and I know whose fault it is, it hurts a little bit. My back hurts. But normally it's not so bad. I get over it. Women report more frequent episodes of pain than men, including more migraines, more tension headaches, more pelvic pain, more facial pain, more lower back pain than men have. Of course, women have to go through childbirth. The childbirth is not the easiest thing in the world. They also have to carry that damn kid for 9 months. And of course, the bigger he gets, the more you got to flip your back backwards so that you can hold that kid up. I mean, otherwise you're falling forward all the time. Anyway, I've never had a headache. I've never had a headache in my life. I'm 68 years old and I've never had a headache. Not a tension headache, of course I've been hit in the head. That kind of hurt. But I've never had a headache, which kind of pisses me off a little bit. People get time off because they're sick, right? Isn't that the way it works? I've never taken a day off because I was sick. So every time I leave someplace, you accumulate these sick days, and then they don't pay you for your sick days. That's not fair, is it? They should pay me for not being sick, right? That's my theory anyway. So I'm going to write that into my contract next time. Never pay me for never missing a day of work. I haven't missed a day of work since I was in the service. And the last time I missed a day of work was because I was having a hangover. I've only been drunk 3 times, and that was one of them. That was stupid. I can remember like it was yesterday. Oh, man. 1975. I haven't missed a day of work since 1975. That's pretty good, huh? Oh, everybody else takes days off. I never get a day off. Gender differences are already apparent by adolescence and in medicine's differential response to the pain reports of men and women. Certain analgesics may be more effective for women than men. Midol, for example. Why in the world do women take Midol if they have menstrual problems or menstrual cramps? Well, it works for women. If a man takes Midol, what does it do for him? About the same thing, but he doesn't have the same pains that you do. So it's working on areas that he doesn't really need worked on. Okay. So some analgesics work better on men than women. Ibuprofen works better on men. Tylenol works better on women. For women, with women. Okay. People at lower socioeconomic levels have greater morbidity and mortality across many diseases. They live more stressful lives, certainly. They live in more stressful environments. They have fewer psychological resources than do individuals with lots and lots of money. Lower socioeconomic status also makes those who suffer from chronic pain more vulnerable to the harmful effects of stress on health and physical functioning. Groups differ greatly in their norms for the degree of to which suffering should be openly expressed in the form that pain behaviors should take. The question is, are people experiencing pain tolerance, or do they have a higher pain threshold? This is one of the questions that we ask when we go to war. Does the enemy have a higher pain threshold or a lower pain threshold? The first time anybody ever noticed this, actually the first time they ever noticed it was in the Indian Wars. One of the things they noticed was that when a native warrior was wounded, that they didn't make any sound, and of course the soldiers thought that was really very odd. And of course you can read stories about how somebody was wounded, or they shot at somebody that they didn't know if they hit him. They found blood, and of course he never made a sound. And eventually they found him wounded or dead or whatever, but he didn't make a sound. During World War I is the first time they ever really talked about it very much. You can see accounts of it in the Indian Wars, but during, actually they talked about it in the Spanish-American War a little bit, but then during World War I, what they discovered was that when Americans were shot, they would grunt. They'd make a grunting sound. Now, when the German soldiers were shot, they said they sounded like women screaming. And you know, I wouldn't even mention this, except I've read it over and over and over again, how the Germans would squeak like a woman that was being pinched or something. It was really kind of bizarre. Anyway, so we all have different thresholds for pain. One of the things we do know from the World War II, the Korean War, and the Vietnam War is that Asians seem to have more tolerance for pain than Americans seem to have. Caution is advised in considering findings of pain research, and mainly it's because if we're looking at a group of individuals, does it include people of Asian descent? Does it include American Indians? Does it include people who are Germans and they squeal when they're shot? You know, that kind of stuff. So you really need to think about these kinds of things. There are different levels of different tolerances for pain. Acute and chronic pain sufferers show elevated scores on 2 Minnesota Multiphasic Personality Inventory scales, MMPI. One is hysteria. Hysteria is a tendency to exaggerate symptoms and use emotional behavior to solve problems. And potentially, of course, if we were talking about Germans, maybe since they squeal like little girls when they're injured, maybe they are more hysterical when they actually get hurt. Hypochondriasis is a tendency to be overly concerned about health and to over-report body symptoms, and of course we would see that as well with those select individuals. People who are anxious, worried, fearful, depressed, and negative in outlook report more pain. If you've ever done a pain study, or you have told somebody that something's going to hurt, a lot of times they will move before you hurt them, as if you hurt them, which is always funny. Of course, I had to hurt people. Well, that was my job. Okay, I had to draw blood from people. I had to stick babies in the people. You know, I had to do these kinds of things. I had to stick people in the finger, you know, that kind of stuff. So I had to hurt people. It was my job. And sometimes I would get somebody that would wince before I even touched them. The funniest thing is when you put the alcohol on their finger or on their arm, and they jerk back like you just stuck them with a knife or something. As bizarre as that is. Anyway, I guess the cold is very painful for me. The subtypes of pain patients, there are 3 different types: adaptive copers, interpersonally distressed patients, and dysfunctional patients. As I was telling you before about the redhead in my basic training unit, he was a dysfunctional patient. He couldn't tolerate pain, and for that reason they boarded him out of the service. Dysfunctional patients will report high levels of pain. They feel they have little control over their lives and are extremely inactive because they're afraid they're going to hurt themselves. Interpersonally distressed patients perceive little social support and feel other people in their lives don't take their pain seriously. And for that reason, they complain a lot. The other type are adaptive copers. These are people who report lower pain levels and distress and continue to function at a relatively high level despite the injury that they're having. What happened to me? Oh, I was playing in a softball game. I have a torn muscle in my left leg. One of my adductors is torn. So if I'm going to show you, but it lumps up on the front of my leg, so I don't have, it's a quadricep, and you're supposed to have 4 muscles, I have 3, okay? Anyway, so this thing was only partially torn. And I was running to second base. This is we were in a game in Chinook, Montana, and it was a ball tournament. It was the first game of the tournament. I ran to second base and I could feel it tear. It popped. I could feel it pop. Of course, I was on second base, and the hit was into the gap between the left fielder and the center fielder. So I went ahead and ran the rest of the way in, despite the fact that my leg was. I was still running. I didn't look very bad. But then I, pulled my pants down. I looked at I had on sliding shorts. Pulled my pants down. I looked at my leg, and it was all bruised, and it bruised all the way up into my groin, all the way down my leg. Well, about the same time, the next inning, I went ahead and played because we only had 10 guys. Then we got another guy in, and so now we've got 11. We got an extra guy. But the next inning, this guy did exactly the same thing that I did. He tore exactly the same muscle, which had been torn before. I mean, it was exactly, the two of us had exactly the same problem. Well, we only had 10 guys. I mean, if both of us had left the game, we would have played with 9, which wouldn't have worked. So I went ahead and played. And it was worse than that because I was a catcher, so I had to get down. And I played the rest of the tournament. We won the tournament. That guy was out for 8 weeks. And if I had stopped playing, we would have forfeited like half of our games. But I went ahead and played. I know. So some people, I was the adaptive coper, and he was the interpersonally distressed patient. We would compare bruises, and my bruises, well, he's a lot younger than I was. But we compare bruises, mine was a lot worse than his. I had more damage than he did. But I went ahead and played, and he didn't. He claimed that I was brain dead, which isn't true at all. I'm not brain dead. You can't feel anything, man. There's something wrong with you. So obviously there's something wrong. Social and cultural factors can influence people's experience of pain and actually lead to social construction of an illness. How we learn to respond to pain begins in childhood. Children whose parents disregard their pain behavior may grow up more stoic in their approach to pain than children whose parents pay undue attention to every minor ache and pain. And this is what my daughter's trying to do with my grandson. What does she say? There's no whining in this house. What else isn't there in this house? Oh, there's no crying in this house either. So if he hurts himself, and the kid is really active, hurts himself all the time, she tells him, there's no crying in this house. And he stops. He stops crying. She's making him tough. I guess she's making him tough. He is pretty damn tough, but he certainly never cries. Not in that house anyway. Pharmacological treatments, analgesic pain relieving drugs are the mainstay of pain control. Analgesics include central acting opioid drugs and peripherally acting non-opioid drugs. And the non-opioid drugs, of course, would be the analgesics, acetaminophen, ibuprofen, aspirin. The NSAIDs are non-opioid drugs. Of course, this is not a very good picture because that's Novocaine he's about to inject in that lady's mouth. Opioid analgesics, formerly called narcotics, are agonists, excitatory chemicals that act on the receptors in the brain and spinal cord to reduce the intensity of pain messages or the brain's response to pain messages. The most powerful and the most widely used are opioids. Of the opioids is morphine. And of course, if you go into the emergency room and you've injured yourself, if you have a heart attack, they'll immediately give you a shot of morphine. That is their protocol, unless you tell them not to. And then they will not do it. But they will still harass you until you either give in or start swearing at them. And usually I start swearing at them. So. I know that works. I know swearing at them will make it work. They don't believe you. Why? Because, and I looked this up the other day, I was thinking, am I the only person that's not sensitive to opioids? Well, I told you this. They did that study in Norway, and they found about 30% of the population has some insensitivity to morphine. And for that reason, it doesn't work at all on me, and I just don't understand it. Fentanyl works, but then again, fentanyl, of course, is a synthetic opioid. It's a synthetic. It's an opioid. Non-opioid analgesics, non-steroidal anti-inflammatory drugs, the NSAIDs, relieve pain and reduce inflammation at the site of the injured tissue. NSAIDs include aspirin, ibuprofen, and acetaminophen. Prostaglandin is the chemical responsible for localized pain and inflammation. It also causes free nerve endings to become more and more sensitized. And of course, it is substance P that NSAIDs will block. Surgery, a centuries-old treatment for pain, is to destroy cells in the thalamus, which hopefully alleviated some deep burning pain. So what they used to do is they used to go into the middle of your brain and they used to destroy some part of your thalamus. Your thalamus is a portion of the brain that sends messages to the rest of the brain. It's kind of like Denver. Denver is all the planes fly into there and then they fly someplace else. It's an airport, but it's, I can't think of the word. Oh man, I'm sorry?
The hangar?
No, that's not the word I'm looking for. It's where people fly into Denver and then they fly to wherever they're going. So it's a hub. It's a hub. So yeah, it's an airport hub. So Atlanta's a hub. Chicago, O'Hare is a hub. So if you want to go to, let's say you want to go to, where do you want to go? Where do you want to go?
Samoa.
You want to go to Samoa. Okay, you can't fly from Albuquerque to Samoa. There is no flight that goes from Albuquerque to Samoa. So in order for you to get to Samoa, you're going to have to fly to a hub. And the hub you'd have to fly to would be LAX. And then you could catch a flight to Samoa. That's the way it works. So if I wanted to fly to Clinton, Iowa, which you can, I'd fly to the Quad Cities. I'd have to fly to Denver and catch a flight from Denver to the Quad Cities. There's no direct flight from Albuquerque to the Quad Cities. It's a hub. All right. So the thalamus is a hub, okay? It gets information and it distributes it throughout the brain. So what they used to do, they used to take a portion of the thalamus and they used to cut it out. And when they cut it out, it had to do with the pain that you were feeling. So they would take out that portion of the thalamus that would send the pain message to another part of the brain telling you that you were in pain. And sometimes it worked and sometimes it didn't. The results of the surgery are often unpredictable and should be considered a last-ditch effort, mainly because that thalamus is a relative, well, it's not as big as the palm as my fist, but it's a relatively large organ, and how do you know which part to destroy? It would be the problem. And if you destroyed the wrong part, of course you would be interrupting something that you didn't want to interrupt. Counter irritation, analgesia, in which one pain is relieved by creating another counteracting stimulus. And this is what a TENS unit is. A TENS unit is a transcutaneous electrical nerve stimulation. In the old days, I can remember when they first invented TENS units. I was working in the clinic in a rural health clinic in Oklahoma, and they had just invented TENS units. And we had all these people with all these pain problems. Everybody wanted one, but of course, at the time, it was like $2,000. Now you can go down to the store and buy one that costs, I don't know, $25 or something. And you get these things that you put on your back or whatever it is for. My wife uses a TENS unit. Doesn't work very well because she's got hip problems. But what it does, it sends interfering messages to your brain. And because it interferes, remember the gate theory, there's only one piece of information that can get through at a time. Hopefully the irritation that you're creating, the electrical charge that you're injuring, it's not really injuring yourself, but you're hurting yourself with, will interfere with the pain message. So the TENS unit really works. It can work, and sometimes it takes the pain away completely. It can take but you can't do it all the time. It's like you can't constantly be stimulating yourself. If you try to do that, then remember the pain has this ability to reroute itself. So what they will tell you to do if you're using a TENS unit is to use it for 30 minutes and then stop for 30 minutes, and then use it for 30 minutes and then stop for 30 minutes. Because if the pain reroutes itself, you're going to have to either move the TENS unit, if you can figure out where to move it, or, well, you're just going to have to turn the damn thing off, because you're going to be getting 2 pains instead of 1, and that is a TENS unit. It doesn't look like this anymore. As I said, you can buy one down at the drugstore. Icy Hot has one. There's a couple others. They all work about the same. It's all just an electrical charge. It's not enough to really hurt you. It just kind of irritates you. Cognitive behavioral therapy, multidisciplinary pain management program that combines cognitive, physical, and emotional interventions. The dominant model for treating chronic pain is with CBT. There's no single pain control technique that has proven to be the most effective in relieving chronic pain, unfortunately. So you have to try everything. And usually you'll have to try everything before they do surgery. So you'll have to try all of these different methods before they will actually do surgery. Many providers use an eclectic approach with pain management or pain patients. I used to work in a clinic in, Montana. I was working in a clinic in Montana part-time where they wouldn't use opioids at all. They wouldn't use opiates. So if somebody came in looking for drugs, narcotics, to help their pain, they wouldn't give it to them. They used everything else in the book. They tried everything before they tried the opioids. Education and goal setting, providing explanation of differences between acute and chronic pain, the mechanisms of gait control theory, and the contributions of depression, anxiety, lack of activity, and other controllable factors to pain. Sometimes the more stimulation you can get to the area, the less intense the pain will be. So inactivity is often the enemy, your enemy, if you are in pain. You need to exercise more. You need to get out and do things. Because if you can pump blood into the area, it's going to be much, much better for you. The reality is if you have an injury, then the more blood you can get to the area, the faster that you'll recover, that you will heal. Generating examples from personal pain experiences and setting specific measurable goals. This is education and goal setting. Cognitive interventions enhance patients' self-efficacy and sense of control over pain. Cognitive errors in the thinking of pain patients. Oh, this is an intense pain. It'll never go away. It's always going to hurt me a lot. You know, it doesn't have to be that way. If you can convince yourself a lot of times, if you can not think about it, it doesn't hurt. So that's what you have to do. You have to distract the individual or force the individual to distract themselves. Catastrophizing, that's what happened with me. I told you that during Christmas break I thought that I had an appendicitis. Turned out to be bruised intestines, I guess. The dog stepped on me. And as soon as, of course I'm thinking, oh shit. I sounded like my mother. They used to say that. Oh shit. I was thinking, oh man, I gotta drive to Salem. I got to teach in 4 or 5 days. So I was really upset because I knew that if it was an appendicitis, I wouldn't be able to do that. I wouldn't be able to drive. Wouldn't be able to sit in the car. You know, what was I going to do? How was I going to? I didn't want you guys to be disappointed. I knew you'd all start crying if you found out that I couldn't get here right away, and I wouldn't be here for a week, and the classes would be supposed to start. Don't cry, don't cry. Okay. So I'm thinking all that stuff, and of course that's catastrophizing, and my pain got worse. As soon as they told me that it wasn't an appendicitis, you know, the pain almost went away completely. I mean, I was probably holding myself in a really strange position, trying to keep it from hurting. Overgeneralizing, and of course that's one of something else that I did. Victimization, self-blame, dwelling on the pain. Of course, I was dwelling on the pain because it hurt a lot, and being a guy, of course, it started hurting like 2 days before I even told my wife I was in pain. But finally, I decided, you know, if this is really an appendicitis, see, sometimes medical knowledge hurts you. I knew that it was really an appendicitis, and it burst, it would kill me. It probably especially kill me since I don't have a spleen. So I knew that it was dangerous and I needed to do something. Obviously I needed to do something. And as it turned out, it didn't kill me. I'm still alive. You're welcome. And I'm here. And nobody had to cry. And Edison would have cried because I got him for like every class. Cognitive distractions divert attention away from the painful stimulus and diminishes self-reported pain intensity by 30 to 40%. So if you can distract yourself, watch television, watch a funny movie, something that you really get into. I mean, this can really take the pain away. One of the things that they have done is that they actually show comedies to people that are trying to recover. If you can smile, if you can laugh, that's not if you've got an abdominal or thorax injury, but if you can smile or laugh, then potentially you're going to be pumping those endorphins, those healing juices into that area of your body, and the pain's going to go away, as strange as that may seem. Cognitive distractions seem to reduce activity in pain processing regions of the cortex, and this is where you're fooling yourself. It's not here. It's not in the part that hurts. You're just not letting the message get into your brain. You're distracting yourself. Something else is happening. Cognitive distractions may engage some of the descending pain inhibitory pathways that catastrophizing seems to disrupt. Guided imagery is a form of self-hypnosis involving focused concentration and attention. Guided imagery is often used to supplement other techniques. Guided imagery is most effective with low to medium levels of pain intensity. Guided imagery is a component of Lamaze training. Of course, Lamaze is where they teach you to breathe. They teach you to breathe properly. Well, what the hell are they really doing? Well, what they're really doing is they're distracted. That's what they're doing. Because it hurts to have a baby. Labor hurts like hell. If we can take your mind off of the pain of your uterus, it's a muscle. Your uterus is a muscle. It's trying to open that cervix up so the baby can pass through. If we can take your mind off of that, then of course you will be in less pain, and possibly you'll be able to give birth with less problem. Cognitive reappraisal is a key component of CBT that focuses on helping individuals reinterpret pain-related sensations, restructure maladaptive thought patterns, and make positive self-statements. Relaxation strategies, you can use meditation, self-hypnosis, exercise, and religious spiritual coping. Of course, we're going to talk about alternative medicines in the next chapter, so next week we'll be talking about alternative ways of healing yourself. Behavioral interventions begin by identifying events, stimuli that precede pain behaviors, those are the responses, as well as the consequences that follow. Treatment focuses on altering the contingencies between responses and reinforcers. I would not want this lady to give me a shot. I'm sorry. She looks like she has no clue what she's doing. When I give somebody a shot, I give them a shot, damn it. I don't wait. Nurses drive me nuts because sometimes they'll stick the needle in, they'll pull back the plunger to see if they're in a vein. Oh, they drive me nuts. It takes them like forever. And look at the look on her face. Just the look on her face pains me. I'm always smiling when I'm giving shots. Mainly it's because I'm kind of a mean son of a bitch. But that's just the way the world works, I guess. Overall, the most effective programs are multidisciplinary in nature, combining the cognitive, physical, and emotional interventions of CBT with the judicious use of analgesic drugs. And as I told you before, sometimes if we can get you to relax, if we can relax that muscle around the pain area, sometimes the pain will go away completely. This has happened to me. I've injured myself, I'm hobbling around, and I've been hobbling around for 3 days, so I take a acetaminophen, I take a Tylenol, and for like 4 hours, the pain goes away. And so 4 hours later, the pain's still gone, and it stays gone. And what's been happening is I've been tensing up, and that's why my leg hurts so bad. And if I can relax that leg, then all the pain will go away. There really is no damage. There's no injury. Effective programs also encourage patients to develop and rehearse a specific pain management program. Both biofeedback and relaxation training are more effective than a placebo in relieving the pain of tension headaches. Across many studies, however, the greatest relief occurred when biofeedback and analgesics were combined. So not only are you telling yourself that I'm about to have a tension headache, but you're also taking an analgesic, which relaxes the muscles of your scalp, and that's really what a tension headache is. Assessment and management of pain guidelines recognize that patients have a right to appropriate assessment and management of pain. They're the only ones that, and the reality is you can't demand that person stop being in pain. It's not going to work. It doesn't work that way. If they think they're in pain, they're in pain. So there's really nothing you can do about that. All you can do is try to give them something that will relieve the pain. Assess the existence, the nature, and the intensity of the pain in all patients. Facilitate regular reassessment and follow-up. Educate staff about pain management and assessment. Some individuals are going to be in pain all the time, and it's because of their psychological situation. I told you the story of the young lady with the migraine headache. She had a migraine headache every time her husband called on the phone and said, "I'm coming home, honey, so get ready, I'm on my way." He's a long haul trucker. "Baby, I'm hot and ready to go." Every time he called her up on the telephone, all of a sudden she'd get a migraine headache and she'd come in. And we cured her migraine headaches. She cured her migraine headaches when she divorced her husband. And actually her husband was a really nice guy. She was a pain in the ass. I'm telling you, she was dress ass. That's what I meant. We had this is the lady that we had the Z-track. We had to stick her, and then we had to twist it 90 degrees, and then we had to stick her, then we had to twist it another 90 degrees, and then we would jam it in the rest of the way. That's called Z-tracking, because otherwise the juice just came dimmer on us while we were shooting her up. It would just come squirting right back out. She was so porous. I mean, we had given her so many shots. She had so much scar tissue in her gluteus maximus and her hip that we had to Z-track her in order to get it to stay. And like I said, we cured her, or she cured herself by divorcing her husband. Actually, we knew that something was going on because she was still married, and all of a sudden she came in and she was smiling. Now, what the hell is this all about? She had a boyfriend. That's what happened. And eventually. Okay. It's a sad story, but it's a happy story at the same time. So everybody was happier, except maybe the boyfriend. I don't know. I never figured out who the boyfriend was. But the husband was happier because he got the kids. She was paid. She was happier because she had a new boyfriend and she didn't have to put up with the husband anymore. I don't know what her problem. Well, I guess I know exactly what her problem is. I told you sometimes she'd come into the clinic and she'd drop trowel right there in the waiting room. She wanted a shot right now. Oh man. Facilitate regular assessment. Okay, so one of the things you need to do is follow up with these individuals. We had it's another migraine story. We had the veterinarian was married to the banker. She was married to the banker, and the banker fell in love with a widowed Italian lady. She was gorgeous, but he fell in love with her, and he divorced the veterinarian. So the veterinarian started having migraine headaches. And every time she saw him, and unfortunately, of course, he owned her lawn, which was kind of a problem. But every time she saw him or saw her, she would have a migraine headache. And when she had migraine headaches, she'd start vomiting. So we would have to take her, she started having migraine headaches, we'd have to put her in a dark room, and we'd have to put a cold compress on her head, and we'd have to give her a wastebasket to vomit into and whatnot. But then she'd come back every day after that, after she had a migraine headache, and we would find out where her pain was. The problem was she was the only veterinarian in town, so if she was having a migraine headache, there was nobody fixing dogs and cats and cows and goats and whatever. So we had to get her back on back to work as quickly as we possibly could. Anyway, so we had to follow up a lot. And before we started following up on her, she'd stay gone for 3 or 4 days. One time she was out for a week. And then we started doing follow-ups on her, and the number of days she was actually debilitated with her migraine headache got less and less and less. And eventually we got to the point where she was only down for a day. She was only down for that day, and then she'd come back, go back to work the next day. Establish procedures that allow staff to prescribe effective pain medications appropriately, educate patients and their families about effective pain management. Toughest thing in the world. Pain is tough. As I said before, you can't tell how much pain a select individual is in. If it's a guy, he's probably going to cut it by a couple numbers. If it's a female, well, it all depends on what kind of female. Most women can really tolerate a lot of pain. I mean, if they've been through childbirth, that's one of the most painful things that can happen to you. Kidney stones are one of the most painful things that can happen to you. But childbirth is really, really painful. And most women just tolerate it without too much trouble. Sometimes, usually. Okay, we'll stop right here. We'll pick this. Oh, we're done with this chapter. So next week we'll